Live streaming is on.
Okay, so this is the live discussion class for Cardiology Internal Medicine Residency Part 1. We're currently discussing the past questions. We've covered most of the topics in cardiology based on what we have in the app, and we're going through the MCQs. So you guys chose majority option C. Let's check the answer now. So that's correct. It said there is evidence of left-sided heart failure clinically. The murmur throughout the precordium and narrow pulse pressure suggests aortic stenosis. So the patient is also predisposed to this by a high cholesterol, okay, like valvular anomaly deposits. All right, so we'll go to the next one. Question number 44. A 50-year-old man had a VFib cardiac arrest while at the railway station. He was successfully resuscitated by a passerby. Coronary angio showed no stenotic lesions in the coronary arteries. What's the next step in management? Send the question number 44 so you can type your answers. Let's drop our answers so that we can move fast. I am on a time. I am on a strict time. You guys chose prokinamide. It is incorrect. The answer is ICD, implantable cardiac defibrillator. Um, yeah, of course. Like when they asked this question, they were like coronary angio. When you see a VFib, what should be the next investigation? It should be like ECG now. So yeah, talking about coronary angio. I'm sure if you do an ECG, you probably see something, right? So a cardiac electrophysiological study will be necessary to help confirm whether this patient has inducible V tachycardia and ablation of the pathways. If so, however, if in a young patient with no coronary artery disease demonstrable, ICD is necessary to trace possible further cardiac arrest. So this patient actually had a cardiac arrest. You cannot just leave him to go like that. Even drugs are not enough. He had a VFib and cardiac arrest, of which he was lucky, and a passerby, resuscitated him. You get so. Leaving it to chance again will not be very nice. So you should actually implant a cardiac defibrillator, ICD. So question number 45. 25-year-old biology student presents with palpitations and has the ECG. Um, I didn't put it. Adenosine is given at 6 milligram and 12 milligram intravenously. He felt nauseous for a few seconds, and there is a rhythm change, sinus rhythm. How does adenosine work? Nice. Okay, these are the options. This one is a simple question. This one is pharmacology. How does adenosine work? Decrease sensitivity of conduction bundle to electrolytes, altering Purkinje fiber response, blocking accessory pathway, blocking AV node conduction, QT prolongation. Question number 45. Someone said it's blocking the accessory pathway. Which other options? Which other others should drop their answers now so that we pick something and move. If you don't know it, you guess. You guess you benefit more when the answer is finally shown. Because definitely, when you see a question, something must come to your mind. It can be correct or it can be wrong, and that's allowed because this is for practice. So when you make mistakes during practice, it's normal, and then you will not make those same mistakes during the actual exam. All right, drop your answers now so that we go to the next one. Dr. Mine, IBK, Abu, and Martins, and the others. Drop your answers to the question. So only one person has answered. Said C. I don't know. Una jump that part for textbook. That one is wrong. Option C is wrong. Blocking accessory pathway is wrong. So the answer is blocking AV node conduction. So adenosine works by slowing its AV nodes conduction, hence breaking the reentry circuit, which can be um, atrioventricular nodal reentry tachycardia or atrioventricular reentrant tachycardia in SVT, right? So, once you see that a patient was given adenosine, that automatically tells you that it is SVT. We've discussed SVT extensively during one of these discussions. We've talked about supraventricular tachycardia, and we have also talked about the management. And we've talked about adenosine, the dose. First of all, you give 6 milligram. After 30 minutes, you graduate to 12 milligram. So it's like after another 30 minutes, you give another 12 milligram. So it's 6, 12, 12, making a total dose of 30 in 24 hours. You cannot go more than 30 milligram in 24 hours. So, yeah. So it works by blocking AV node conduction. All right. So we'll go to the next question. Question number 46. 10-year-old patient has Down syndrome. He has he has over the past year become progressively more breathless. He's losing weight and feeling lethargic. He is also becoming blue when that's cyanotic when running with a dog. Okay, which of the following cardiac lesions might be responsible? They've already given you the clues. Sef. All right, number.
Please, Dr. George, I can't see the screen. I can't see your screen.
What I did was convert my phone from portrait to landscape. So that was how I was able to see it. If you can do the same, maybe it will help.
Thank you very much. Hmm.
So I said, we can't hear you again.
Can you hear me now?
Yes, I can hear you. I can hear you
Okay,
now.
all right. So I was reading the question. I was reading the answer. You saw that the answer was wrong. Now the one that this guy chose, option C, was wrong. So the correct option is the one that is green. That's ventricular septal defect. Hope you are seeing the cursor moving on the screen.
Yeah. Yes.
So the explanation here: an endocardial cushion defects can lead to ASD or VSD, right? So with rapid deterioration of VSD, you can have breathlessness and cyanosis, which are the features that was described in the question. 10-year-old Down syndrome patient. So I think one of the things you need to know is like the features of Down syndrome, like the cardiac complications. Let's check the cardiac complications of Down syndrome. So Down syndrome can cause the most common cardiac conditions seen in children with Down syndrome are AV, um, atrioventricular septal defects, okay, which can be atrial septal defect or ventricular septal defect. Do you get now? So it can cause both ASD and VSD
Yes, sir.
or AVSD. But then it can also cause pattern ductus arteriosus and TOF. So the person that chose TOF, fine, it's correct that is also one of the things that can happen with Down syndrome. But like the presentation is different. Like this one is progressive, and this patient is 10-year old, right? Has become progressively breathless and is losing weight, feeling lethargic. Also cyanosis, right? Uh-huh. But like the commonest, TOF can also present with this picture here. Okay, but based on like the commonest complication, because they didn't give us any other extra thing that will make us to pick one or the other. Do you get? But the commonest complication of Down syndrome, the commonest cardiac complication of Down syndrome is a ventricular septal, atrioventricular septal defect, right? So we go to the next one. Question number 47. A 60-year-old man presents with central crushing chest pain radiating to the back. He has a weak pulse in the right arm and systolic blood pressure is 120 millimeter of mercury in the left arm, 80 millimeter of mercury in the right arm. Okay, so which one of the following is a feature of severity requiring immediate surgical action? This this description is giving you something. Anyway, it's giving you a diagnosis. So let's answer. Question number 7. Nori, you are raising your hand. You want to talk? Like you saw something like this. This is the picture. You know, this was what's the diagnosis that's coming to your mind, and then which of these features, like symptoms, will you get in the patient, and you know that this patient will need a surgical, you know, an emergency surgery immediately. Which of these symptoms? Answer now. Persistent vomiting, headache, pulmonary edema, hypertension, loud diastolic murmur in the aortic area. Someone chose A, someone chose E. Someone chose D. Somebody should break the tie for us now. Break the tie. Okay, so that's okay. There are many options. Option A is okay. Let's see now. Resistant vomiting. Resistant vomiting is wrong. The correct answer is loud diastolic murmur in the aortic area. So like just like someone typed in the comment section, based on these differences in blood pressure between the right and the left arm, it suggests aortic dissection. So hypertension should be treated with an infusion such as labetalol. A loud diastolic murmur in the aortic area suggests aortic regurgitation. Okay, so aortic regurgitation and pericardial effusion, that's hemopericardium, suggests dissection down to the aortic root. So, like when you have aortic dissection and like it's going, the aorta arises from the left ventricle, right? So, if it gets towards the root, then apart from just having aortic dissection, you are going to now be having aortic regurgitation, and of which blood can also seep into the pericardium. So you now start having pericardial effusion, which can lead to cardiac tamponade and all those stuff. Remember, cardiac tamponade and can lead to death, right? So like there are emergency features that you need to attend to immediately, because it means if it can dissect up to the aortic root, then there's going to be serious cardiac complications. So these features are, or persisting chest pain suggest that the patient requires prompt surgery. So the last one is the answer, option E. So we'll go to question number 48. 66-year-old man presents with tearing chest pain radiating to the back. I know what confused some of you. They said crushing chest pain, right? But some of these things are textbook definition. Like tearing is classically aortic dissection, but when you say crushing, it feels like as if it's myocardial infarction. But they also told you that it's radiating to the back. So when you see chest pain that is radiating to the back, you know, of that nature, and is causing hemodynamic instability, you should be thinking towards aortic dissection. Okay, so yeah, 6-year-old man presents with tearing chest pain radiating to the back. See that same recurring train of thought, radiating to the back. Okay, the pain started 5 hours ago and is continuous. He has a past medical history of previous stroke, hypertension, and osteoarthritis. His blood pressure is 180 over 95 millimeters of mercury. There is an early diastolic murmur in the aortic area, and the chest X-ray showed widened mediastinum. This one is also pointing to something. An urgent CT of his chest with contrast shows a dissection flap. What is the best treatment at present? So, what do you do for this patient? One is IV amlodipine, IV labetalol, IV tirofiban, oral sodium nitroprusside, and clopidogrel. Question number 48. Someone chose labetalol. Martins chose B. Now, when I answer, make we choose. Okay, the B is habits. They gave you the answer in the previous one. The explanation to the previous one carried this answer. They said that labetalol should be used, and obviously, usually it comes with hypertension and discordant hypertension, kind of like one side of the right arm will be different from the left arm. So when you are suspecting aortic dissection, the signs you look for, it means you measure blood pressure in both arms and compare and contrasts. All right, and also the pulse will be weak on the other side, on the affected side, right? The history and CT scan findings confirm aortic dissection in this case. Blood pressure control is vital in the early management of aortic dissection because, of course, you know that if aortic dissection is not controlled, what will you have? Prior to considering cardiac surgery, the best initial treatment is IV labetalol or IV sodium nitroprusside. That's the second line, sodium nitroprusside. But labetalol is number one. Okay, so we'll go to question number 49. 70-year-old woman has a history of palpitations for 4 months. An ECG at that time showed atrial fibrillation. She was given digoxin, diuretics, and aspirin. She now presents with two short-lived episodes of altered sensorium, altered sensation, okay, in the left face, arm, and leg. She also had intermittent dysphagia. There's poor coordination of the left hand. An echocardiogram was normal, as was a CT scan of the head. What is the most appropriate next step in management? So the options: carotid endarterectomy, anticoagulation with warfarin, clopidogrel, corticosteroid treatment, no action. Question number 49, right? Okay, we have the C's have it. Seems we have. You guys want to add clopidogrel, right? Have you calculated the Charles score? What's Charles score? Who can answer now? Somebody should answer. What's Charles score? And how is it calculated? And don't you think it will be beneficial to calculate it in this patient? Dr. Mine, what's Charles Bass? So you are the one that said you are moving stuff after we discussed it here. You can talk, oh. Just unmute yourself and talk. You can. I don't expect you to type it. This is a recorded this thing now, so you need to talk so that for record purposes. Just unmute yourself, talk. No be it's not one sided, it's from all angles. We teach each other. So what's Charles score now so that we answer the question and move on?
Um,
Who is talking?
It's a
Can you hear
it's
me?
a score that is used to
Okay,
assess.
Dr. Alba.
Uh, use- is a score that you could use to assess the need for anticoagulation in the patient that has AFib.
Okay, yeah, you're correct. So what is it like?
Okay. Can I talk? Can I
Yes.
comment? All right.
Okay.
Just like she said, so the score, if you have two and above, it means the person have a higher risk of having a stroke. So you are expected to use an anticoagulant. Then less than that, you can use antithetic. So the score involved C for cardiovasculars if someone have a previous history of um, cardiovascular disease like stroke, give a 2 point. Um,
Hmm?
H,
C is for
sorry,
what?
CCF,
CCF.
congestive heart failure, yeah. Then H is hypertension, give a score of 1. A is age greater than 60, age greater than 75, give a score of 2. D is diabetes, you give a score of 1. X is cells, if the patient is a female, you give a score of 2. V is if there is any vascular diseases, previous vascular diseases,
No,
you give a
the
score
first
of
S.
1.
No.
Okay, sorry, the first S is previous stroke.
Yes, that's
Yes,
true.
the previous stroke. Yes, you give 2. And then for the other A is age between 65 to 74, you give a score of 1. Then the last S is sex. If the patient is female, give a score of 1.
Okay, what did you say V is?
V is vascular diseases like
What?
DVT or peripheral vascular disease.
Yeah, peripheral vascular disease.
Mm.
All right. Okay, so yeah, you're correct. So how many distance do you think this woman will have? What score will you give this woman based on what we said? She
Mm.
has
Female 1,
huh? Yeah,
71,
she's
2.
female. Yeah.
Yeah. So it's 2. Okay, previous stroke.
Mm-hmm.
Right. Yeah, she had a previous stroke.
That's four
Okay.
already.
Oh, so she's
Mm.
to
She's supposed
have
to
it.
start
But
coagulation.
yes, but the anticoagulant here, that's the problem. It's warfarin, supposed to be heparin. So, can we still choose?
Hmm. Okay. But yeah, because usually you don't start with rain straight ahead, right?
Mm,
She has also had intermittent poor coordination on left hand. But the problem is that she now presents with, do you get
mm-hmm.
point at this point, like she's either she's having a TIA or another stroke.
That's true.
So first of all, yeah, okay, they said a an echo was normal and CT
CT.
scan, head CT was also normal.
If this were the acute phase, it should be normal.
Yeah, depending on the type of stroke. Like if it's
Ischemic.
ischemic stroke, right? During the acute
Yeah.
phase, yeah, it can be normal. So yeah, but let's see the explanation. So the patient has thrombotic events related to atrial fibrillation. Hence, formal anticoagulation is recommended. The age and stroke gives her a CHAS score of 3, CHAS-VAS score of 4. CHAS-VAS score is the updated one now, so we use CHAS-VAS score. So so I think the answer is B. Okay, you can see it's blue, it's green, right?
Okay.
So the answer is B, anticoagulation with warfarin, regardless. Because for that thing not to show up on the CT scan, it means it's likely an ischemic stroke. And usually people that have that kind of repeated strokes secondary to atrial fibrillation, it's likely, and at her age as well, it's likely going to be from ischemic stroke.
Mm.
Mm. Okay, so we go to the next one. 13-year-old boy had a syncopal episode followed by generalized jerking of all limbs whilst having dental filling. He was particularly nervous about the procedure. When he was assessed in casualty, his blood pressure was 140/80, oxygen saturation 99%, and ECG showed normal sinus reading. What's the likely diagnosis? Option A, generalized tonic-clonic seizures. B, vasovagal syncope. C, carotid sinus hypersensitivity. D, VF arrests. And E, meningitis. So the number 50, have I typed it? Option B is finito. What's vasovagal syncope? Dr. IBK, what's vasovagal syncope? Or vasovagal syncope, depending on how you want to pronounce it. Who is saying that it's not connected? It's something that we are having discussion right now. You're saying it's not connected. It's your network.
Someone is already answering.
Okay. Dr. Ibukun, give us answer now. Unmute yourself and answer. And we don't want to talk about it. Now we move. Question option B.
It's more like a stressful condition that is causing a sudden uh, shutdown of brain flow to the blood flow to the brain. So, like the vagal nerve stimulating, I think it's related to stress.
Okay. That's not the answer anyway. The answer is generalized tonic-clonic seizures. You mentioned vagal nerve, which is parasympathetic. Don't you expect the blood pressure to drop during vasovagal syncope? You expect the blood pressure to drop, but here they give you the blood
Yeah,
pressure was
yeah,
increased.
it should drop. Yeah, I agree.
So if blood pressure was increased, then it's not like vasovagal syncope. So during normal seizure, normal generalized tonic-clonic seizure, you can have elevated blood pressure as a result of you know the spasms. So vasovagal syncope is not uncommon during a procedure which a patient is frightened of. There may be transient brain hypoxia, which may cause generalized seizure-like activity. Okay, but it's a generalized tonic-clonic seizure. So, a 60-year-old male diabetic patient presents to the clinic. He takes metformin, bendrofluazide, and aspirin. He has had a previous myocardial infarction but is currently asymptomatic. His BMI is 33.5, has a pulse of 90, blood pressure 160/90, cholesterol level was given. Okay, what is the most appropriate therapy for this patient? Option A, ramipril, clopidogrel, nicorandil, orlistat, and simvastatin. These are the options. So you should just try to identify what is missing from the management. What are the if you can identify the problems of the patient and the drugs they are giving and the one they have not treated, probably. I forgot to type, but just drop your answers. Okay, two persons have chosen ramipril. Yeah, that's the answer. When you see a diabetic that is hypertensive, your drug of choice should be an AC inhibitor or ARB based on normal. Okay, because diabetes can lead to diabetic nephropathy, which will present with proteinuria. Proteinuria is like the first sign of diabetic nephropathy. So AC inhibitors and ARBs have anti-proteinuric effects, so they are renoprotective. That's why they are preferred. And if you check the patient's management, patient is already on a diuretic, benzodiazepine. However,
They
his
are really very
blood pressure is still not controlled. Okay, so that tells you that he needs an add-on. Although, like, if you were the doctor in charge, you should have started the patient on this and add on something else. Okay, all right. And all this one they are writing simvastatin, orlistat, and all those stuff. The patient's cholesterol level is normal, although it will still at some point you may still add it, due to there's something called cardiovascular index. Okay, so that's even if the fasting serum lipid profile is normal or appears normal, depending on the number of you know comorbidities, you may still give them low dose simvastatin, right? Okay, so question number 52. 21-year-old woman has a history of palpitations and lightheadedness. ECG shows short PR interval and inferior Q waves. Her symptoms improve with atenolol, 25 milligram per day, but she has had two short episodes of similar symptoms in the previous 24 hours. What is the long-term management of choice? Hmm, have we answered this question before? The answer is already there. But what's the diagnosis based on the ECG you're seeing? There's shortened PR interval and there's delta wave. What's the diagnosis? Yeah, Wolf Parkinson White syndrome. That's the diagnosis. It's classical now. It's classical. Once you see that delta wave, it's a feature of Wolf Parkinson White, like accessory pathways. Okay, and then shortened PR interval. Because it's passing through an accessory pathway that doesn't have that normal AV nodal delay, you now have a faster impulse transmission from the atrium to the ventricle. So that's why the PR interval will now be shortened. Check our previous discussions. We've discussed arrhythmias very well. Okay, so the answer is already obvious, but the answer is radio frequency ablation. That's the definitive management, and they were asking for the definitive management. That's the long-term treatment of choice, which is definitive management. So radio frequency ablation of the accessory pathways, that's the treatment. So diagnosis is Wolf Parkinson White syndrome, and patient has had atrial tachycardias which are not controlled by medical therapy. Should be referred to a cardiac physiologist for radio frequency ablation of the accessory pathway. This should be the last question for today. 55-year-old man presents with chest pain, facial flushing, and elevated JVP, but no leg edema. He had been exposed to TB in childhood, had a strongly positive tuberculin skin test, and has been followed up in the tuberculosis surveillance program with regular chest x-rays, but had never been diagnosed with tuberculosis. Chest x-ray on presentation showed calcified plaques and masses in the pericardium and mediastinum. Coronary angiography showed 70% stenosis in the left anterior descending artery. Cardiac catheterization showed equalization of diastolic pressures in all four chambers. What is the what's the likely diagnosis? And this is like the image of the what we are describing. So what's the likely diagnosis? Pericardial effusion, cardiac tamponade, constrictive pericarditis, sarcoidosis, angina. Okay, someone chose option B. The answer is constrictive pericarditis. I even showed you the answer when I was showing this thing. It's there in the image. It's constrictive pericarditis. When you see that cardiac catheterization, polarization of diastolic pressure in all four chambers. Okay. All these graphs, you go and check it out anyway. So I think that's where we'll call it a night for today. Till next week. Do you have any questions about that? About what we've talked about so far?
So I just wanted to ask, all these questions, are they covered in the slides on the app?
Yeah, we've discussed them everything together before. We've discussed all the questions. If you've not opened your app, all the
No, I've
topics,
opened it.
all the topics are there. Then the
Okay.
question, you mean the questions themselves, the ones I'm showing.
No,
Therefore,
no,
the
no.
app,
Are they covered? Are the questions on the app?
the questions are in the app. The topics have been covered in the app. The update slides
I
are in the
noticed
app.
the topics.
The
I noticed the
videos,
topics were there, but I'm not sure I took note of the questions like this. Maybe they are in a PDF format or something.
how would they be in the PDF? They are there in the app. Like you're seeing me clicking it and it's responding. Is it a PDF? See the when you go to the cardiology section of the app, okay?
Okay.
Cardiology and vascular medicine. When you scroll down, you see all the topics there now.
Okay.
Then all our previous discussion videos are there too. We have
Okay.
put all of them there. Then this one is cardiology MCQs part 1A. That's where we are.
Okay. Okay. So
When we
yeah,
finish,
I've not explored enough then.
I know
Thank you.
when we finish the
Yeah.
questions in cardiology, then we enter respiratory. That's the next topic. So that's
Okay.
how we'll be doing it.
Okay.
All right. Any more questions? Okay, before we go, what did you learn today now? Everybody will talk. Tell us one thing that you learned that you go home with. Let me start from the first person. Abu, Dr. Abu. What did you learn today before we call it a night? Just say one thing that you learned. I learned about this. I learned about that. You don't have to explain it. Just say I learned this. Okay. Dr. Mine, what did you learn? IBK, what did you learn? Dr. Greg, you came late. The
Yes,
person,
just come joining now.
I saw you. Dr. Noya and Dr. Nori.
For me, what I learned was the vesical syncope not presenting with hypertension, basically.
Okay, okay. Yeah, that's a good point. What did you learn, Dr. Mine?
Okay, I learned that if there is a difference in blood pressure between the right arm and the left arm, it signifies aortic dissection.
It can also signify it just signify that there is an obstruction along the pathway of blood that should go
Okay.
to the upper limbs. Then there's this thing where you can also detect mm, coarctation of the aorta when you have like a difference between the upper limb and lower limb. Difference in pulses, like when you check the pulse of the upper limb and the pulse of the lower limb, and there's a difference. Okay, or pulse of one arm and the pulse of the other arm, and there's a difference, like they are not matching. That's one of the things that you check in pulse. You compare both limbs, both upper limbs and both upper and lower limbs. Okay, so yeah, you have a point. You are correct. Um,
Okay. Hello.
okay.
So what I learned is that
What's
for
your
those
name?
with, I'm actually Greg. It's just that I find it difficult adding my name to that, writing my name. I don't know.
But there's
Anytime I write,
another one that's having your name, Dr. Greg Ikechukwu.
I'm not. It's a different person.
Oh, okay.
Uh,
No
so
problem.
I learned that those that have what is it called? Um, active deception can involve the altitudes, and when it happens, it gets, you hear a loud and solid murmur, and the best option is to get surgical intervention.
Okay. Yeah, that's a very nice point. That's a very nice point. Well done. Okay, Dr. Abu Sharon. She's gone off. Dr. Mine. Okay, no problem. I believe everybody learned something. So we'll call it a night. Bye bye.
Yes, sir.
Till next week.